So, good evening, Dr. Joseph.
Yeah, good evening, Dr. Seba.
Good evening, everyone else. So, welcome to our Sunday Afro DX Clinic Unknown. So, today I'll be presenting a short case to Dr. Joseph. So, I hope it's going to be very interesting and also very impactful in terms of our learning and clinical practice. So, maybe Dr. Joshua, we can start with the first slide. You can move. So, today I'll be presenting to you a 35 years old male who presented with a chief complaint of recurrent headache for 10 years.
Yeah, thank you very much, Dr. Seba. So, sure, when people say short case here, usually they become difficult cases. That's according to David, and I think it's true. Let's see for today. Yeah, I think we have never discussed headache here, but if we have, then I forgot. So, headache is among the very common complaints that we see, and it's good for every one of us to have an approach to it. So it's a simple thing. It goes two ways. If you see headache, it says a primary or secondary. 10 years makes a big difference. It's hard to be a secondary headache for 10 years. But for the sake of this discussion and educating each other, we can start with that component that a secondary headache usually something that is present anywhere in the body. For example, you can have a malaria and have a headache, for example. But if you see in the structures of the head, from the scalp to the inside, anything, if there is a problem with anything, and the structure sitting on your head, like the eyes, the teeth, the nose, the ears, they can all cause secondary headaches. Of more important, and I think which will be the case in this case, is someone who is having a headache for 10 years. So, primary headaches, you all know migraine, probably, and you also all know tension headaches. But there are others. For example, there's a group called trigeminal cephalgias. So, different headache belongs in this group. And so we will see as we move on what are the qualifying characters of this headache, and probably we can put in one of the primary headache syndromes. Yeah, I think it's to you, Seba.
Yes, thank you, Dr. Joseph, for a good introduction. So maybe, Dr. Joshua, we can move to the second slide. So this recurrent headache for 10 years was on and off. So it was gradual onset, progressive. So it was throbbing in nature, more marked on the left frontal region. So initially it starts with mild intensity, then with the maximum peak on the third day, and it usually persists for up to 2 weeks. Then it gradually subsides. So it is reported to be precipitated by extreme fatigue, emotional stress, aggravated by light, extreme noise. However, it was not relieved by over-the-counter anti-pain medications, rest, or cold compression. So on next slide. So it was associated with stuttering, which was characterized by repetition and prolongation of words, dizziness on and off, which was non-posterior related, with a sensation of surrounding being moving. There was also blurred vision, together with reported short-term memory loss involving recent events. So next slide. So this was also associated with recurrent conversions, which were sudden in onset, and reports to occur mostly on the fourth day after the onset of headache. So it was characterized by generalized movements, which was muscle rigidity, rhythmic jerking movement involving the extremities, with an episode lasting for about 3 to 5 minutes with no specific periodicity. So there was no change in character of the conversion over time. Also, there was reported loss of consciousness for about 1 to 2 episodes. So not all the times in which he had conversion had reported loss of consciousness. So sometimes he had loss of consciousness, sometimes it did not report loss of consciousness. And with the period of loss of consciousness was reported to be about 5 to 10 minutes with a delayed registration of the surrounding. So this was not associated with tongue biting, saliva drooling, fecal urine incontinence, a period of deep sleep, confusion, neck pain or stiffness, jaw pain, or other abnormal movement apart from the ones which were reported. Next slide. So this was also associated with a recurrent right-sided weakness, which was also gradual onset involving upper and lower limb extremities, progressive worsening with time. So it usually occurred within 3 days from the onset. From the onset, the patient is unable to move against gravity. Then it was followed by persistent weakness for 6 to 7 days. Then it gradually regresses. So it was preceded by numbness, and this numbness was reported to start from the wrist and sole at the same time, then spreading up to the face. So it is associated with unintentional tremors on the right upper limb, at rest with increasing with activities like holding objects. Also, there was reported intermittent spasm lasting a few seconds with no specific periodicity, involving both limbs. In severe occasion, patient could present with difficulty in breathing associated with high-pitched harsh sounds. So there was no mouth deviation that was reported. There was no facial weakness reported. Next slide. So there is no history of unintentional weight loss, excessive drenching night sweats, no cough, no chest pain, no awareness of heartbeat, shortness of breath on exhalation, lower limb swelling. There was no skin itching or rash, reported sensitivity to sunlight, no dry eyes or mucous membrane. There was no bleeding or abnormal discharge from the nose, gums, or skin. There's no reported mouth ulceration, heat or cold intolerance. There was no anterior neck swelling that was reported. So back to you, Dr. Joseph. I think this was our HPI.
Yeah, thank you very much. So, can you go? It's a bit long HPI. Can you go to the first slide of HPI and I can start from there? Yeah. So, as I discussed from early on, that a 10 years history of headache has to be a primary headache. And I think I'm going to delve on that. So I touched on a little bit early on when you presented the chief complaint, but I think this HPI and for headaches, primary headaches, you need just history. So I think we have to have a diagnosis by the time I discuss this HPI. So I said when we say primary headaches, migraine headaches, you all know it, and tension headaches, you all know it. When you tell people to mention primary headaches, they say migraine tension cluster, but that will miss some sort of headaches. It should be migraine tension and trigeminal cephalgias. And then in the group of trigeminal cephalgias, now you have, I think, like 4 headache syndromes. The one is the cluster headache. Another, I think, is uh, I think it's the hemicrania continua. The other is paroxysmal hemicrania. And the other two, they have very difficult names. I remember their short forms is SUNCT and SUNA, very rare headache syndromes. And so the trigeminal cephalgias, they don't look like this kind of headache that is presented here because they have autonomic features. Patients will be having headache, and then they'll be having tearing, reddening of the eye, and stuff like that. They're usually short-lived, and they are unilateral and stuff like that. People with tension headaches usually don't even come to hospital. These are the people who sit home to say, I have this headache when I'm tired and stuff. So it's a bit easy. The person you usually present to the hospital, if you remove the group of trigeminal cephalgias will present to the hospital. Migraine is another one that will present to the hospital. So if I do elimination here, and if I think at the end of the day we have to have a primary headache syndrome here, if I've already realized this can't be trigeminal cephalgias, it also can't be tension headaches. It has to be migraine. So I'll look at this headache and select the to and against points for migraine and see if it fits. But there are other components of this history that you've seen they are realizing. So I'll try to put them and see if they fit on in the presentation of migraine. So migraine headaches is the debilitating headache that present with other features. Debilitating in terms of this patient, when they have headache, they can't do anything else. And there is a mnemonic, I think, of the symptoms called, I think, pound. Yes, the headache is pounding. The onset is rapid. It's usually unilateral, associated with nausea, and the D is for dizziness. So you look at these, and I've heard Seba talk about these symptoms, some of them in this mnemonic pound, and this headache of this patient is debilitating, and it has other symptoms. So, like you see, fatigue and emotional stress. These are other symptoms. Other headaches shouldn't have these kind of things. I think. Can you put the next slide? And I see there are other symptoms that came up. Yeah, yeah. So dizziness, bad vision, things like photophobia, they are usually present in migraine headache. So stuttering, and then another slide. Yeah, here. Now this will be a bit difficult because there is also conversions. We are told initially we are discussing headache, and now we are discussing a seizure. So, in a solving a case, it's not about getting the case right at the end. The most important thing is knowing the problem of the patient, because if you know, for example, the problem is seizure, it will be very different if the problem is primary headache. And if you know the problem, even if you don't have enough information, when you go and read around, you just maybe Google the problem and you get what you want from that case. So because we are presented with another problem here, which is a seizure, and it's also for 10 years. Now it's the work of a clinician to sit, realize if the headaches can go along with the seizure, or if the seizure is the primary problem and headache is just another thing. For example, I'll give you an example. If you have ever seen one epilepsy syndrome, I think it's called temporal sclerosis. It has other symptoms. This patient might have a bit of headache, and they can have confusion. They can see things or smell stuff, and then they start convulsing. But it will be hard to explain recurrent headache in 10 years and with other symptoms that point toward the side of primary headache being migraine. So if you think probably this is not a seizure and headache is part of it, the only other option will be this is a primary headache and seizure is part of it. So will that fit in the category of migraine? And the answer is yes, although it is rare. If you've ever heard of the term, I think, migraine with aura, and you all know when you study about, for example, if you study about stroke, when you are told, you asked, tell us about the mimickers of stroke. The first thing to mention is migraine with aura. It can mimic a stroke. And also, Seb, I think he also told us in one of the slides there is also hemiplegia, right, Seba?
Yes, the next slide.
Yeah. So there is also hemiplegia. Now, migraine with aura can have other issues that reflect a failure of the CNS. But there is another word that is also creeping in my mind other than migraine with aura. When you read migraine with aura, there is another also called hemiplegic migraine. Now I should realize that the difference between these two, migraine with aura and hemiplegic migraine, so because hemiplegic migraine is distinct category of migraine. And seeing this, the recurrent light-sided weakness for 10 years with a headache, I'll say this is hemiplegic migraine. And a seizure is part of an aura, and it fits that category, than the category of saying this is a seizure syndrome and headache is part of it. Because if it's a seizure syndrome, it won't explain the recurrent right-sided weakness unless probably Seba would have told us the seizure, the convulsions were unilateral. Because yes, if it was unilateral, after seizing, you have a post-ictal state, and you have paralysis of that side which was seizing. But what I realize here, these are generalized conversions. Is both the both the half of the brains are involved. So it won't explain anything that why should someone have a unilateral weakness afterward. So I think the main problem here is headache, and this headache have to be migraine, and we are dealing with hemiplegic migraine slash migraine with aura. Seba will teach me later how do I differentiate the two. Yeah, so that's where I am, Seba. If maybe you can continue the case.
So thank you, Dr. Joseph. I think that was an excellent introduction and also run through the HPI. So should we move ahead?
Yes, sure.
So in the review of other system, it was unremarkable. Then coming to the past medical history was also unremarkable. The family and social history also was unremarkable. So there was no significant history of headache that is associated with focal neurological deficit for the past 3 generations in his family. So in the general exam, patient was fully conscious, febrile, not pale, no jaundice, no oral thrush, no aphthous ulcer, no angular stomatitis, no lower lymphedema. So there was no any neuromelanocytic lesions or caffeolate spots, no purple peripheral lymph nodes, no stigmatas for chronic liver or kidney disease. So vitals were normal. So in terms of the systemic exam, nothing abnormal was detected in all the systems. Anything to comment from the?
Yeah, I think of importance to comment there is the exam findings, the neuro case, and exam findings is very important. So if neuro exam was normal, and the patient has been having problems for 10 years, these are the problems that come and go. When you are seeing the patient on that day, they're okay. So problems like this are just few if they're coming from the CNS. Uh, so it,
I
for
think
example,
we can't hear you well.
Hello, Seba. How about that? Hello. Can anyone else hear me?
Yes, now we can hear you.
Okay. Okay. I don't know if it's my internet or yours, Seba. Can you hear me now, right?
Yes, yes, I can hear you.
Okay, good. So I was commenting on the exam findings that the neurological finding being normal, and patient has been having trouble with their neural system for 10 years, and you are seeing them, you're examining them, they are normal. It means you're seeing a problem that comes and go. uh, so there are no many problems that can give you weakness, and you are seeing the patient, they are normal, but they have this problem recurrent for 10 years, seizure being one of them. And other stuff that came up, migraine is another one. Migraine with aura, by the way, or hemiplegic migraine. um if I have, I don't think if I have others. If this was a secondary headache, for example, let's say there was something sitting in the patient's brain for all these years, let's say very slowly glowing, we should see findings, because there is no way that this thing should be coming up, giving a patient weakness, and then going away after some few minutes. So still, it says more and more that we're dealing with a primary headache syndrome, because we see a seizure syndrome is less likely here. Yeah, I think we should continue the investigation, Seba.
Hello, Joseph. You are breaking out.
Uh-huh. You don't hear me well, eh? I think I should shift my spot. Hello? Hello?
So coming to investigation,
Seba, can you hear me now?
so a CBC was done which had normal parameters. The metabolic panel in the renal function and liver function tests were all normal. Serology was negative. Thyroid profile was within normal limits, and the ANA profile was negative.
So,
So lumbar puncture was done, which was also normal to this patient,
hello, Seba?
and brain imaging was done, which was the brain MRI, which was done, which also had normal findings. Yes, can you hear me, doctor?
Yeah, now the slide were not moving. Okay, but I was hearing everything. So you said the labs were unremarkable, and here's the brain MRI, right?
Yes,
Okay, I think we should.
and brain MRI had normal findings.
Yeah, sure.
Yes, so EEG was done to this patient, and the conclusion was normal awake and sleep record with no any epilepsy from discharges reported. Yes,
Yeah, that's it.
yes, that's it.
Yeah, this is really a short case. Yeah, so very important is the MRI that's telling us uh, there is nothing structural to be seen in the brain that is causing the symptoms that we are seeing, and so we expect that in 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 migraine with in migraine, wherever migraine. Another very important investigation here is the EEG. So this EEG is called interictal EEG. Patient is not seizing, and you're putting an EEG and it reads some stuff. Being negative doesn't rule out a seizure. So you depend on a history. You depend on a history. You go back and think. But I think I've gone through this in the HPI that I think the main problem here is not a seizure. A seizure is part of a primary headache syndrome, and So yeah, still I'll be there. I'll say this is a hemiplegic migraine, or someone might also call it a migraine with aura. So that's my diagnosis if I don't have other things.
Yes, I think the approach was right. So even the final diagnosis to this patient was also a hemiplegic migraine. So just some few learning points. So hemiplegic migraine is the rare subtype of migraine with aura. So as Dr. Joseph, you're saying hemiplegic migraine vis-a-vis migraine with aura. So one of the subtype of migraine with aura is hemiplegic migraine. So it is characterized by presence of motor weakness and an aura manifestation at the time of attack. So it may be sporadic or it may be familial. So for the familial hemiplegic migraine, it's usually an autosomal dominant type that only occurs in rare reported with an about prevalence of about 0.01 in the general population and predominantly affects females with the ratio of about 2.5 to 1. And some studies have reported up to a ratio of 4.3 to 1. So in terms of the typical pathophysiological process that happens, it's usually an inherited channelopathies in an autosomal dominant fashion. So these inherited channelopathies, they can be divided into three types. So you can have familial hemiplegic migraine type 1, in which patients have defects in the calcium channel calcium channel receptors. Familial hemiplegic migraine type 2, the defect is usually in the sodium potassium. Then for the familial hemiplegic type 3, usually more resembles the type 1. So it is usually characterized by a migraine attack that include the motor weakness during an aura phase. So an attack usually includes a severe headache. Patients may have visual field defects, and they may have numbness and paresthesia, and they may present with a hemiplegic a weakness. Sometimes patient may be aphasic. They may also have fever. And as correctly as Dr. Joseph was saying, seizure is just a part of the primal headache syndrome, which is the hemiplegic migraine. And in some severe cases, patients may present with status migrainous, in which you have very severe form of migraine headache lasting for more than 72 hours, and sometimes they may present even with a respiratory derangement. So how it usually starts, usually motor symptoms. So usually motor symptoms start in the hand and gradually spread in the arm and face, and the symptoms can last for hours, days, and sometimes they may go up to weeks. For example, in our patients, they usually have at a time frame of about 2 to 4 weeks before starting to recede. So as Dr. Joseph was saying, so hemiplegic migraine is a clinical diagnosis. And to know if this is sporadic or if it's familial, then a meticulous family history is required to differentiate the sporadic type and the familial type. So we have the diagnostic criteria, which was kept in place by the International Headache Society, the third edition. So a patient must have at least 2 attacks fulfilling the criteria for migraine with aura. Then after having more than 2 or more attacks of migraine with aura, the aura should consist. So this is a motor aura, and the motor aura should consist of full reversible motor weakness and a full reversible visual, sensory, speech, or language symptoms. And also, this should not be accounted by any other diagnosis. So the aim of doing investigations such as brain MRI is usually to rule out presence of the mimics or other alternative diagnosis which can explain the symptomatology the patient is having. So at least one one first or second degree relative with an attack with an attack. If you're having a first or second degree relative who presents with a hemiplegic migraine, then that is going to be a familial hemiplegic migraine. So lumbar puncture is usually useful in evaluating for the condition. So there is an important, very close differential diagnosis to familial hemiplegic migraine, which is known as a headache with neurological deficit and CSF lymphocytosis, which is famously known as the Handley. So a very close differential to hemiplegic migraine. They present almost the same, but the difference usually comes in the lumbar puncture. When you perform lumbar puncture, patients with Handley, they present with significant elevated lymphocyte levels of more than 15 and above. So there is a role of genetic testing so that you can be able to confirm the types of familial hemiplegic migraine, because we have type 1 up to 3, and they have some form of different management. So genetic testing is important to know what is the exact type of familial hemiplegic migraine so that the patient can receive an appropriate treatment. So management, so it follows the same sequence, all patients having migraine. So the first line is for patients who are having an acute attack, then these patients have to be kept on abortive therapies. So abortive therapies, depending on the severity of the attack, all the way from the NSAIDs. But of strong importance to note here, patients with familial hemiplegic migraine, usually one of the commonly used abortive therapies, such as the triptans and the ergotamines, literature suggests that they should be avoided because they've been associated with a more increased extent of cerebral vasoconstriction, which may worsen the cerebral ischemia. So preventive therapy is recommended just as per the guideline of International Headache Society. Patients presenting with 3 or more headache attack in a month, these are the patients that they're supposed to be on preventive therapies. So preventive therapies, they can range all the way from non-dihydropyridine calcium channel blocker, which is verapamil, has been heavily mentioned, especially for patients who are having a prolonged aura. For example, a patient had an aura which would last for 2 up to 4 weeks, or frequent aura. So a patient was a candidate of receiving a non-dihydropyridine calcium channel blocker, the verapamil. So patients who are having a predominating headache pain, there is a role of flunarizine, which is the calcium channel blocker and anti-migraine. If not available, then also there is a role of using antidepressants such as amitriptyline. So acetazolamide has also been mentioned in patients with familial hemiplegic migraine because it has been shown to improve symptoms, specifically for patients who are having type 1 familial hemiplegic migraine. And the other important part is the non-pharmacological part. So all the triggers such as stress, lack of sleep, and different kind of diets which can be triggers for migraine, just like the red wine, cheese, and so forth, should be avoided.
Yeah. Thank you very much, Dr. Seba and Dr. Joshua. So, yeah, I should mention one thing. When Seba presents the case here, his teaching points are, I think, they trump everyone else. They are usually well packed. Thank you very much. It's a class. You remind me a lot. And yes, I didn't know that. Actually, I've never taken care of hemiplegic migraine. So a learning point that I didn't know is we should avoid, because it's easy to dash out the gotamines and the somatriptan to these patients. So we should avoid that. So you mean abortive therapy will remain to be NSAIDs?
Yes, NSAIDs, IV paracetamol.
Yeah.
Yes.
Okay. Yeah, that's
Together with the role of metoclopramide also has been
yeah.
heavily suggested. Yes.
Yeah, that's very good. Yeah. So this was a very nice case. Migraine. There are a lot of migraines around. And I sit in clinics. I can tell you, these patients go around with headaches. They have never been told they have migraine. They just say these headaches. Have been told whenever I have a UTI, I have these headaches. You have to, if you sit and listen, headache, debilitating headache are associated with other symptoms like dizziness, nausea, general body malaise. You have to come up with the diagnosis, and many of them will need preventive therapy. It's just amitriptyline at the night, and they go on with their own lives. So yes, headache seems simple, but the international classification of headaches that you're mentioning, it has more than 100 syndromes, although we know these few. So headache is a bit of a challenging thing, although it seems simple. So, for example, in this patient, you might think 10 years. I believe someone else at one point might have said this is an epilepsy and not a migraine. So, yes, I thank you, Dr. Michael Kisoka, as usual. A nice comment. So, I think I shouldn't say this is a Todd's paralysis because Todd's paralysis, the paralysis after a seizure. So if it is unilateral, the seizure has to be unilateral. It has to be focal because that part that was seizing later is the one that will be down and weak. But this patient was having generalized conversion. Unless it would have, if the story would have been like it starts focally and then spread to involve both limbs. So I dismissed the Todd's paralysis in that way. But thank you very much for the comment. Yeah, thank you, Seba. So, do you have anything else from the chat? Any comment? We still have time today. Seba, anything from you?
I think this was a good starting learning point, especially for the part of headache. So I think headache was thoroughly exhausted, especially if we have the junior colleagues, the undergraduates. This was the best forum for them to learn about primal headache. How would primal headache present vis-a-vis secondary headaches? Just from the timing itself, as you started, Dr. Joseph, a headache of 10 years, more likely you're dealing with primal headache in contrast to having a possible secondary headache.
Sure.
Yes, together with the point also of the other trigeminal cephalalgias, I think it was an important learning point. Yes.
No. Do you happen to remember the long form of Suna? I don't. I think it is.
No, I think I'll have
It
to go
is.
and review it again.
It is short-lived unilateral neuralgia, and I don't know. You have to Google it. Yeah,
Yes.
yeah, it was very rare. Thank you everyone for showing up. I think we are going to close. Have a good night. See you next week.